and you are knocked to the ground, you put your hand out to touch yourself, and so you're kind of in just a neutral position here, and a 300-pound guy smashes into your elbow from the top here, and your elbow, which was previously straight, now is inward like so. So it's facing backwards, basically. That would tell you that probably there's a dislocation in bones. The bones are not where they're supposed to be, and ligaments, tendons, muscles are probably all torn. So that's a pretty complicated fracture. I have my forearm, and this is an intact forearm. Oh, he just broke his forearm. My students really like that. They can do crap. Okay, so here's his elbow and here's his forearm. So your forearm, if you look at your own, it's not supposed to bend in that place, close to the wrist there. And that's a range, there is motion there. That forearm will just go every which way. Horrible forearm, right? So that's excessive motion. So if you're working the ER and your doctor's busy with someone who's having a myocardial infarction or has some massive head trauma and they don't have time for an arm injury, so you go in there, it's not your job to assess, but it is your job to kind of check things over and see what's right and what's wrong. And one of the things we will talk about was mostly when people strain their ankle, for example, they just can't hardly turn it. It starts swelling immediately, and there's no movement. This will swell immediately too, but you can see just by the position it's in that it has mobility in places it's not supposed to have mobility. So that tells you, that if a forearm will turn into almost a square, that's a very bad thing, right? So I worked really hard on this, by the way. And I'll tell you what, I had a test question the last few years that analyzed poorly. And it was not my test question, it came from the test bank that came with the book. So I thought, well, I'm going to turn on the light. Okay.
Ms. Martinez, would you make sure your student mic is turned off because you're sounding real distant, but we're still hearing them.
Okay, okay, all right. There we go. Thank you, Mr. Baird. So, my test question analyzed poorly, and I thought, well, this is a test question that was written by professionals. It's probably important. Your option as an instructor when your test question analyzes poorly, you can throw out the question and say, I'm just not going to teach that. Or you can say, I'm going to teach it better. And I thought it was legitimate to try to get a couple of things across to you that I hadn't managed to do. So I decided I would try to make a demo, and now I'm going to go to my slides. So, desktop here. And my slides should come up pretty quickly, and I'll go to the slideshow, and we will get rolling. Beginning. And there will be like 2 minutes of review. I wrote, on this posture, shoulders up, belly in, face where you are going. So your chin up a little bit. Don't look down when you're walking. Have good posture. Okay. I just made myself a couple of notes. No change in this one. No change in this. Oh, I changed I had changed something in humidity. It had to be hydration. And hydration is in the book, and so is humidity. But to me, hydration was so logical, and it said external factors. And I think hydration is an internal factor. Whether you drink or not seemed to me to be more of an internal factor. Oh, my lecture capture stopped blinking, so I'm going to touch it again. Okay, it seems to be going again. All right, So I basically went back through to see if I wanted to add anything to what we'd already covered. And so it's not going to take me very long to do this. Okay, what I added to this slide is the large font at the very bottom. The Best Exercise program has a combination of isotonic and isometric, so stretching. Stretching is something we've kind of people my generation have tended to overlook, and they've lost a lot of their range of motion and mobility as a result. So I'm trying to make up a little bit of lost time there with myself, but I want us to teach our clients in the hospital and our family members how important it is to do 5 or 10 minutes of stretching a day, so that when they get older, they will still have mobility that they need to brush their hair or brush their teeth. Because when you lose your independence, it does such a number on you. Okay. Then we talked about the stasis in the kidneys when someone lies in bed, the urine tends to pool in the kidneys, and then the calcium that's in a liquid state tends to kind of leak out and calcium calculi form or stones form. Now, renal stones, kidney stones can be made of other things besides calcium, but calcium is a fairly common type, so that does happen more often in people who are spend a lot of time in bed, who are very sedentary and have limited mobility. That's not always the case. You can be very active and still get kidney stones that are made up primarily of calcium, but this is one of the ways that they happen. So I added that to my slide for next year, but I wanted to make sure you guys got it too. Okay. And I'm getting close to where we were. Okay. I think this is where we were. We talked about the flexion and extension, a little bit of hypertension. Abduction is away from the midline. Adduction, you're adding it toward yourself. Eversion is outward. Inversion is inward. So that's kind of easy to remember. I know we've got just a little bit further, maybe this is a brand new slide. And we talked about osteoporosis, and I don't know that there's anything on this slide that we didn't cover, but I decided I should have a slide. And that green line through the middle of it, I can't get rid of that line. I'm going to have someone else figure that out for me. So I also used, I think it was page 372 in this book, talked about osteoporosis. It's a different, I want to know what, promoting health in older adults is the name of that chapter. So I just kind of put together the things we had already talked about on a slide. Women, higher risk than men. Thin, slightly built, small bone women are at the most risk. Asian and Caucasian are at higher risk than other ethnicities so far. Weight-bearing exercises do make a difference to keep osteoporosis at bay. It probably isn't going to, if you're predisposed to have it, if it runs in your family, if you have that body type, if you're female, you're Asian or Caucasian, you may still develop osteoporosis, but you may not have it as severely, or it may come on later in your life. Taking supplemental calcium and vitamin D can help some, but generally it has to be prescription meds to really get much difference. I think doctors still encourage women who are at high risk to take supplemental calcium and vitamin D, but it hasn't been shown to be super effective. Smokers, higher risk than non-smokers, and I know we talked about that. Okay, so something else that I didn't make a slide about, but I wanted to talk about, because our emphasis really, when we're in the hospital, we have, you know, we have some young adults, we have some middle-aged adults, but most of our clients are older, because as you get older, you kind of the cumulative wear and tear on your body, and just the natural course. You know, we lose about 1%, I think, of our kidney function a year after maybe age 40. 1% isn't bad, but no matter what you do, you lose a certain percent. That's why if you're, I think 50 was the cutoff when my uncle needed a kidney, because I couldn't even apply to be his kidney donor. I was like 52. So you already, for whatever reason, they want, you know, younger people have more kidney function. So if they're gonna put someone through the risk of the surgeries, they want a younger, more functional kidney. Older people tend to walk with their neck flexed, and leaning forward a little bit. They usually take shorter steps, they have a wider stance, and they don't pick their feet up as high. And sometimes they tend to look down more than straight ahead. All of those things, other than the wider stance, put them at higher risk for falling when they're walking. Not picking your feet up, you're more likely to trip. You know, they shuffle along. It doesn't take much to trip you if you don't really pick your feet up. And the wider stance happens because of changes in their skeletal system. It's sort of like a pregnant woman has a wider stance. If you're walking along the ocean and early in the morning and there's only been 2 people who have walked on the sand before you, and one of them's footprints are maybe 5 or 6 inches apart, and the other ones are a foot or more apart, you can say to yourself, okay, that's either an older person or a pregnant woman, and you're generally going to be right. So you can become a professional tracker just like me. I'm not. I can't tell a badger from a coyote. My dad doesn't know why, but I think he's explained it to me, and then bobcat, I tend to get them confused. So anyway, there is a difference in how we walk, and when you get out there in the community and you're in the grocery store, watch some older people walk, and you will see they're not picking their feet up as high. They have a broader base, probably to give them a little more stability, but I really think it has to do with some shifting, some very subtle shifting in their bones. And they tend to lean forward a little bit, too much sometimes, which makes them at a fall risk. And sometimes they have their neck flexed too much. And I'll just give you a brief commercial like Mr. Baird does once in a while. If you got your first cell phone when you were 12, and you started spending, untold hours a day on your phone, looking down at your phone, looking down at your computer, your laptop, your iPad, whatever, you spend the majority of your day doing things like that, and then you sleep in a flex position with your chin tucked a little bit, you're going to start losing some flexibility in your neck. And then you're going to be a dangerous driver, because you're not going to turn your head very far when you look to see if someone's in the next lane. And you see people like this all the time who have lost range of motion in their neck. When they turn their head to the right, they can't get over their shoulder. They can just get maybe 3/4 of the way. And you can't see very well who's beside you and all right coming up behind you like that. You know, the mirrors are better than they used to be, but they're not perfect. So older people get into more car accidents, and it can't be as simple as stretching and going through some range of motion for 5 or 10 minutes once a day. Okay. Let's see. So you all are going to have bent necks, and it's not pretty. You're going to be, by the time you're 50, most of you will be walking around with bent necks, and you'll probably have to have surgery because it'll hurt. And then you'll be have problems in your employment. So I'm painting a really negative picture because I want you to do range of motion. That's it, that's all. Just trying to help you out a little bit. Okay, on to sprains. Sprains involve ligament injuries, often partial or even sometimes a complete tear. And the ligaments stabilize our joints. Somehow my entire sentence didn't get in there that I was working on, but I was trying to say what you most commonly see is an ankle roll or twist, and you're watching an NBA game on TV, not that you have time to do that, but if you do, and somebody twists their ankle or rolls it really bad, they usually show it a couple of times. And you see that ankle roll over, those ligaments have to give way to allow that ankle to move that far. Typically, they're going to have immediate pain with swelling. There's some instability because if those ligaments aren't intact, that hold our joints the way they're supposed to be held, then it's going to shift a little bit. But they're not going to be able to move that ankle typically very far, and probably because of all of that swelling and pain. Treatment is rest, ice, compression, and elevation, and most often NSAIDs. So that is a sprain. And a strain, it involves muscles and sometimes the attaching tendons, the tendons that attach the muscle to the bone. So you may not have immediate pain with a muscle strain. If you carry a really big bag of groceries and you bend over kind of improperly to put it in your trunk, or you're trying to get a big bag of dog food out of your trunk, and it's really cold outside and you're stiff and don't bend quite right, you might not hurt immediately, but the next day you may be hardly able to get out of bed because of that back pain. That's most likely a strain instead of a sprain. So the pain is more delayed with a strain. And you may see bruising. You're probably going to see swelling, probably not as much as you saw with a sprain, but you may see some swelling and also some decreased range of motion because it's stiff and sore and you don't want to move. And the treatment, you're really going to use ice for either one. You're going to try not to overdo it, but anything that is swollen, elevation above the heart is one of the things you're going to want to do to decrease the edema, and rest it for a couple of days. Now, most of us have a hard time doing that with a muscle strain. Even a sprain, I see people limping along because their lifestyle is just too hectic and they can't afford to just stay home 2 or 3 days. I mean, if you called your clinical instructor and said, I sprained my ankle, I can't come to clinical, we might say, put an ace wrap on it or a boot and do your best to get there, We don't want you to miss if there's any way you can function. And your employer might do the same thing. They might say, oh, gee, we need you so bad. It's a sprained ankle. Your brain's still working. If you can find a way to get here, we'll try not to work you too hard. Well, yeah, sure. But anyway, so that rest is harder to do. It's easy to say, hard to do. But obviously, we will heal faster if we rest it. The ice packs, this is a little different. It seems like when I worked in the ER, we'd say, 30 minutes of ice packs out of every 2 hours. But I think in your book, it might have said 15 minutes in one of these chapters during that first 48 hours. And mostly that ice is to also constrict the vessels and cut down on the swelling. So you start to ice as quickly as you can after you realize you're injured. and take it off when it gets uncomfortable. But there's a kind of a rebound thing that I think you'll learn maybe in adult one about if you leave the ice on too long, it actually causes more problems than it helps. But we're not going to go into that. You don't have to know that. Just know the rice and the insects. Yeah, the rice.
And it's for both of them or just?
It's for both of them. Well, you really can't compress a muscle, probably. Depends on, depends on where the muscle is. If it's your back, I've seen people wrap themselves with an ACE wrap or try to use some compression on their backs. Even those back melts, I've read, those lumbar supports, haven't been shown to do a lot to help. You see the guys in the grocery stores and in the lumber yards wearing them a lot. There's not a lot of research to say that they actually reduce injuries or improve healing, but sometimes they make people feel a little better, and if you feel better, then there's no reason. I don't think they cause any harm. Okay, so a fracture. How a fracture differs. I showed you my elbow here, but we were talking about ankles because you've probably seen more ankles. Some of you have had fractures, or have helped patients who've had fractures or really bad sprains. I've had a couple of patients tell me that were athletes and got injured, multiple times, that a bad ankle sprain hurt more than when they fractured, their femurs or something. I don't doubt it, really. It probably just depends on the person. But we tend to think of a fracture as requiring more pain medication, but in actuality, I think it depends on the person and the severity of the fracture. Some fractures are not misaligned, and they're even hard to see on x-ray. They're almost a crack more than a big, grossly deformed fracture. So those don't hurt as much as a bad sprain might. So what I was trying to show you on my elbow that bent the opposite direction was that you can have more range of motion with a fracture if the bone and the ligaments, everything is torn. You may have muscles torn. You may have, if you have a really bad fracture and everything's torn, then you can have more motion there, abnormal excessive motion than you would normally have. So we immobilize it, right? That's one of the first things that you do, is to try to keep that from moving any more than it has to. If you come upon an accident in the field, they try to splint or wrap, because the more it moves, you may have damage to blood vessels, you may have damage to nerves, other tissue is going to get hurt if it can, and little muscle bone splinters can also damage more tissue. So trying to immobilize is one of the first things there. But the biggest difference here was that you would see more motion than you typically see. You see motion that your joint's not supposed to have if it's a fracture in a joint, or motion in an area of the bone that doesn't normally have any motion at all, like in your forearm. Okay, treatment, probably, sometimes they're gonna have to go to surgery. Like I said, if it's not misaligned, if it's an alignment, it's not a severe fracture, sometimes the mobilization and some medication and ice and whatnot are about all you need. But they're gonna get x-rays, they're gonna prescribe NSAIDs again. Sometimes you'll have short-term opioids that are a little more restrictive with that than they used to be. Sometimes some muscle relaxants. There can be muscle spasms when the muscle's torn and injured. So muscle relaxants help with that type of pain. and then they may end up in surgery. Okay. This is a new slide, and this is an elbow. You see that the ball at the end of the humerus is not in the socket. So you've got the radius ulna at the bottom, the two bones that head toward the wrist, and your humerus is outside of the socket. So this is a dislocation. Plus, it's a fracture because the other tip of that humerus is broken off and sitting down. That second arrow is showing you a piece of bone that has broken off of that humerus. Now, I would imagine they would have to go surgery and remove that bone. It's kind of a little bit bigger than what you call a chip, but I guess it's a bone chip. And I would hope we would not try to reduce this dislocation in the ER because of that bone chip there. I just don't think that would be the right move. Sometimes dislocations are fixed under moderate sedation without going to surgery, but the really severe ones have to be done in surgery, and especially if there's fracture as well as bone chip, or fracture as well as dislocation. So I thought you might enjoy seeing an X-ray. And this one had two things wrong with it, so that was worth inserting. Okay. This one was even cooler, but I can't get it to open. Darn it, huh? Okay. So effects of immobility. Disuse leaves our muscles weak or flaccid, and will they eventually atrophy. That will be on your activity pretty soon. Disuse osteoporosis leaves our bones weakened. Now, you know, there's other types of osteoporosis. It's kind of hereditary. Like I said, there's times that you're going to get osteoporosis no matter if you do everything right. But about virtually everyone will get osteoporosis if they're in a coma lying in bed. The calcium leaves the bones. That's all there is to it. Contractures. If you do not do, if the employees who work with a comatose person or a person who can't move their own joints, do not perform range of motion, then contractures eventually develop. And that's when the flexor muscles are stronger than the extensor muscles. So they pull everything inward. You know, the chin usually pulls up, the arms pull up, the knees are flexed tight. It's really hard to turn these people. It's really hard to clean them if they're incontinent. And the only way to really fix this, because eventually it becomes permanent, those muscles shorten, the tendons and ligaments shorten, the joint gets kind of frozen from calcium deposits, and the only way to help it is an operation. And sometimes if someone has one contracture, they'll go in and do a surgery. But if they're fully contracted on all their extremities, maybe that would happen. I've not seen that happen, but I've seen surgeries I've seen people sent to surgery to try to fix out one. And then the joint deformity that happens with foot drop, and there's a good picture, I think, of foot drop in here, is from lying supine, and it's just for long periods of time. And it's a natural, I don't know that it's a natural position, but if you close your eyes and think about yourself stretched out, your foot is not going to be pulled up and flexed. It's going to be relaxed in that position. If it's left in, well, just like in, So, if it's, left in that position for long periods of time, then that becomes something that, is permanent too. And I believe there might be surgery for that. That's called plantar flexion contracture, or the common name is foot drop, but I'm not familiar with that. And then, let's see, your book, it's on the same page, it's on page 1022, talks about when the joint becomes ankylosed or permanently immobile. The connective tissues just, which mainly is excess calcium. As the bone demineralizes, the calcium leaves the bone, it tends to settle sometimes there in the joint, and then that joint becomes immobile. Let's see. There are more effects. We've talked about several body systems, but not all of them. Activity intolerance is kind of a general activity intolerance in that, you know, you walk from your couch to your kitchen to get a cup of coffee and you're exhausted. And these are people who can only take a very few steps without becoming very, maybe their heart jumps up, their pulse jumps up, their respiratory rate increases, might start getting a little dizzy, and they are likely to fall. And that's kind of a systemic, but probably primarily cardiovascular effect of immobility. Okay. I think most of you are familiar with this, but active range of motion is what we can do for ourselves or our clients can do for themselves. If you demonstrate the range of motion they should have in a joint and then ask them to do that too, and they can do it by themselves. They can go through the complete range of motion that would be expected of them. That's active range of motion. If that person is not mentally able to comprehend what you're asking them to do, or they're just very weak, and you end up moving all of their joints through their range, that's passive range of motion. A lot of times this takes place during the bath. It seems like a good time, unless they're going to tend to get too cold. But as you wash their feet, it's easy to do range of motion on their ankles. And you wash their legs, it's easy to do range of motion on their knees and hips. So it doesn't take a lot of time, and it really does benefit that person a lot. And then active assist is where they can do part of it. Maybe they can lift their arm part way, but they cannot, maybe they can bring it forward and flex it, but they can't raise it at all above their head. It doesn't really hurt, they just don't have the strength. And it doesn't really hurt if you take that arm and help them raise it up. So that's active assist. And a lot of times that's what you end up doing. They can do part of it, you finish it for them. And then I think about that, about the shoulders and elbows, because those people who can't brush their teeth or comb their hair, that loss of independence really affects their self-esteem and how they view themselves, and can really affect mood, make depression a lot worse. Just being able to do little things for themselves improves people's mood and sense of self. If you are helping someone with range of motion, stop when you feel, when they say it hurts. Don't try to force a joint to go past where it wants to go. Okay. So we have, I think, in previous chapters, talked a little bit about things nurses need to do, addressing infertility, but it's just so important, and we're going over briefly again. Assess your clients' mobility, their bed mobility in particular, and chair mobility. If they, you want to know how much risk is present for pressure ulcers or falls. And I know I think one of my last days at the hospital, a lady had fallen. She was maybe 89, and it sounded like she was alone because she had one of those alarm necklaces, and her family checked in on her a couple times a day, or maybe they didn't. It was a little unclear. Supposedly they did. Well, she said that she had fallen and she hurt. I think it was a hip, and it was a femur closer to the knee. Anyway, she said it hurt and there was swelling present. They took her to the ER and they, said, yeah, you hurt yourself. Take it easy for a few days and send her home. Well, she went home and sat in her chair for about a week and developed pressure ulcers on both heels and her coccyx. And they brought her back to the ER and did more extensive radiology, and she had a fracture she had osteoporosis pretty badly. She had fractured that leg, I think, previously and had some hardware, and they decided she was not a surgery candidate because they couldn't go in and really put any more hardware in because you can't pin something that's spongy and it's just going to fall right out. Those pins are going to come out. So I don't really remember what the end result of that was, but I was annoyed that on top of the fracture, she ended up with like 3 pressure ulcers to go with it. So that was disturbing to me. And my lecture capture has gone on. I don't know